Okay, so I'll start from the beginning. Sinus bradycardia is the first atrial dysrhythmia, or sinus dysrhythmia. So this is one of the evil stepsisters of normal sinus rhythm. The only thing wrong here is the rate. Okay, the rate is below 60, but all other measurements are within normal limits. These are the known causes. So it's a long list. So this is what it looks like. These are the causes, signs and symptoms. Usually, depending on how bad the heart rate is, how low rather. The decision whether or not to treat it depends on whether or not the patient has signs and symptoms. So as already said here, all characteristics of sinus bradycardia are the same as normal sinus rhythm. What's the only difference? Except for the rate. Okay. And the causes are not exclusive here. There are more causes listed here. Okay. And then there are specific interventions depending on if they fall under these causes here. For instance, if the heart rate results from stimulation of the vagus nerve, such as bearing down during defecation, then what's your intervention? Do you want the patient to continue bearing down? Okay, obviously not. Okay, so treat the constipation. And as already mentioned earlier, these are the medical interventions. Okay, then also non-pharmacologic is the vagal maneuver. No, that's for the sinus tachycardia. Sorry, I got confused. And we already discussed the frequency, okay, and how to give and the dosing of the atropine. Then for sinus tachycardia, these are the known causes. So for instance, if the cause is from dehydration, so what would you do? Do you give metoprolol? Okay, you give fluids, right? You treat, again, this is always aimed toward what is the specific cause? So if you can identify the cause, then eliminate the cause, treat and eliminate the cause. If you don't know, then we'll have, what other choice do we have? We have to treat the dysrhythmia. So what's the treatment for sinus tachycardia? What drugs will lower the heart rate? Okay, so well, not yet. That's not really the first choice. Okay, so we start with beta blockers, right? So we can do calcium or beta blockers right here. So we got beta blockers or calcium channel blockers. Now we only do, I will discuss synchronized cardioversion on a separate section because it has its own page because it's just very small description here. It doesn't really discuss the procedure. So here's the vagal maneuvers. Now, as far as adenosine, again, adenosine is more for a what we call SVT, or if the sinus tachycardia is no longer sinus tachycardia, meaning it's now supraventricular tachycardia, which has a heart rate of 160 or higher, then we will have to use adenosine. Okay, so adenosine also discussed separately under SVT. We'll skip sinus arrhythmia. This is not really a common dysrhythmia, so we'll skip that. So far we've got sinus bradycardia and sinus tachycardia. Okay. Let's go now to the atrial dysrhythmia, starting with a PAC. A PAC, or premature atrial complex, is usually a harmless dysrhythmia. Doesn't really cause any symptoms. The only patient complaint here is they feel like their heart skipped a beat, because technically it did, right? So here's a PAC. An example of a PAC is, you see the P wave here, and then a P wave. Now, if you look at the underlying rhythm, the P wave is supposed to occur somewhere. Let me use my So this is the P wave right here, right? so here, paper's not long enough, but let's just. Okay, let's just say. Okay, let's extend it here, okay? So the P wave is supposed to be this interval. But if you look here, from here to here, so that's the P, correct? But when you go here, the P is supposed to occur here. But what happened here? It occurred too soon. But you can see what follows the premature beat. There is a pause. Right? So there's usually a pause after a PAC. The same thing also when you see a PVC or premature ventricular contraction. So premature atrial contraction, you can easily identify because it will be followed by a pause. It's like the heart saw the premature beat, it felt it and then said, what just happened? And then it reset. And then the underlying rhythm resumed. Okay, so every time it happens, there will be a short pause about up to, let's say, 1.5 big blocks worth of pause. And then after that, there will be a resumption of the underlying rhythm. Okay, that's what a PAC is. Yes, John? No, it's not a U wave. Okay, it's a U wave again is different. So what causes PACs? Well, more common than you think. Coffee. So this is the first dysrhythmia caused by a coffee so far in this chapter, and we'll see more. So who drinks a lot of coffee here? Okay, so you're not aware you may be having PACs and PVCs already. It's also listed here. Yes, so besides coffee, alcohol, smoking. So here, anxiety, hypokalemia can also lead to PACs. Right?
I really think I just had a PAC.
All right.
Do you have a PAC when you're in the roller coaster?
Yeah, because that causes anxiety. Yeah. Okay, we're interrupted here by this table. So let's go ahead and discuss this table. So how do you use this? These are the treatments for your various dysrhythmias. So the most testable part are which columns? The last two, side effects and nursing interventions. But I want you to see and look at the side effects, okay, for each drug, for each row. What do you notice? No, side effects. Okay, so this one causes prolonged QRS, QT. These drugs, lidocaine, causes bradycardia. Okay. Flecainamide, propafenone. Yeah, this one even causes heart failure. Okay. Look at this next one. So acetabitol, atenolol, these are beta blockers. What do they cause? Bradycardia. And I can go on. Amiodarone, bradycardia. Those are dysrhythmias, correct? Keep in mind, these are anti-dysrhythmic agents. What are their side effects? Another dysrhythmia, correct? So you'll notice a term mentioned throughout this table. Proarrhythmic. Proarrhythmic. What does that mean? Pro means for, correct? For arrhythmia, meaning you have to keep in mind that when you administer any of these drugs, what's the potential side effect? Another dysrhythmia. Okay? So that's what proarrhythmia means. So this is something to keep in mind. So whenever you decide to use a drug to treat a dysrhythmia, always prepare for a different dysrhythmia. Are we clear? I mean, it makes sense why it does that, because if a drug is able to change a rhythm, that means it will cause a different abnormal rhythm. All right. And these are your responsibilities. Okay. So make sure you have, when it says, let's say, look at this drug here, amiodarone. So of all the drugs listed here, this one I've had pretty bad experience with. So whenever I give this drug, something happens to my patients, right? So I try not to give it if I mean, maybe it's just bad luck because it doesn't happen to other nurses. But in my experience, I have no problem with PO. I give it PO, no problem. It's the IV form. Whenever I administer it, something happens to my patients. Right? So my patients most of the time go into right here. So we give amiodarone. What are the possible problems? Here, polymorphic dysrhythmias. Okay, the patient we go into torsade de pointe, which is not listed here. Okay, so that's a type of polymorphic VTAC. Okay, that's dangerous. That can go into VFib. Right. So, and these are the only two calcium channel blockers that are approved for dysrhythmias. So this one is very effective for AFib, A-flutter. See, it treats atrial dysrhythmias, right? So these are effective against atrial fibrillation and atrial flutter. Okay, so management now for PACs. So similar to sinus bradycardia and sinus tachycardia, do they really require treatment all the time? No. If PACs are infrequent, no treatment necessary. However, if they are more frequent, meaning more than 6 per minute, that's a lot of PACs. Now we will have to do what? Okay, we have to treat it now. First of all, initial treatment, of course, is to identify and eliminate the cause. Causes, again, are listed here. So from the smoking to alcohol, anxiety, hypokalemia. Okay, so if you can identify any of those, then treat it. If not, then monitor the patient more closely, notify the physician, because we may need to prepare for a more serious dysrhythmia coming, right? Think of it as a warning sign that something more sinister is about to happen, all right? Next atrial dysrhythmia is atrial fibrillation. Now, there are two problems here. This is the most common type of dysrhythmia for the elderly. So most chances are half of us in this room may develop AFib once we turn 65 or older. It's the most common age-related dysrhythmia. There are two results here. Let me show you the strip first. Okay, so this is AFib. Do you see P waves?
No.
There are no P waves here, but you have you see so many waves that look like P waves, right?
Yeah.
Okay, but they're not P waves. This is not a P wave. That's not a P wave. That's not a P wave. P wave is a nice and distinct curve, right? So these are not P waves. That's not a P wave. Okay, they look like P waves, but they're not true P waves. They're what we call fibrillatory waves. So again, if we see a P wave, what two things happen? No. When we see a P wave, what two things happen? What contracted? The atria contracted and the impulse came from the SA node, right? Remember, we just did that this morning. So therefore, there are no P waves. So what two things did not happen? There is no true atrial contraction and the impulse did not come from the SA node. Where did it come from? We have no idea. But something is firing these electrical impulses, not the SA node. Okay, so what could happen? What could possibly go wrong if the atria are not contracting and the impulses aren't coming from the SA node? There's no, since the atria are not contracting, is blood leaving the atria? Very little is leaving. So therefore, is it any different from your blood staying in your legs?
No.
So what could happen if blood is pooling in your legs, or in this case, blood is pooling in your atria? Blood clots will form. Okay, so that's one problem. The other problem is depending on the rate, because good thing if the AFib has a rate which is between normal, between 60 and 100. What if it's not? Usually, the heart rate here is over 100, can reach 160 or even higher. And we already discussed earlier what happens to cardiac output whenever the heart rate is too fast. Cardiac output drops. So there are two results here. Loss of atrial kick, meaning cardiac output will drop, meaning blood pressure will drop. Patient will go into shock, correct? And then second is, what will the patient develop? They will form blood clots. Okay, so two things can kill the patient. If the low cardiac output doesn't kill them because the heart rate's so fast, the blood clot will. So blood clot, depending on which side of the atria has the blood clot. So let's start with the right atrium. If the patient develops a clot in the right atrium, what could they develop? Trace the flow of blood from the right atrium. Where will it go next? And you have a clot already in the right atrium. Where will it go first? The patient will develop what if it gets to the lungs? A pulmonary embolism. What if the clot is on the left atrium?
Going into the body.
So what will the patient develop first? What's the first organ that receives that blood clot? It's already on the left atrium. Where will it go next? Just trace that blood. You are a blood clot. You're in the left atrium. Where will you go next? That heart will pump you out. Where will you go? The brain. Patient will have a stroke, right? Remember, first organ that gets blood is which organ? The brain first. What if it misses the brain? Where will it go? It missed it. Remember, blood will come out of the aorta. It didn't quite reach the brain. Once it falls back down during diastole, where will it go? Into the coronary arteries. So can it cause a heart attack? Yes. So lots of AFib. The clotting can cause a heart attack, a stroke, or a pulmonary embolus. But most of the time, it will cause a stroke. Okay? Because most clots form on the left atrium. I'll show you a left atrial appendage. I don't know if it's here. Okay, right here. So on the, let me show you a picture of the left atrial appendage. So this is your left atrium. It has not all people have this, but some people do. This is a left atrial appendage. Think of it as like an extra arm or an extra finger, okay? So it's in the left atrium. When somebody has this is think of it as a riverbank. You know, at the sides of a river, wherein you see water get caught between the rocks. Okay, kind of like that idea. So if you have a left atrial appendage, blood clots usually form here because blood will get caught here, right? Similar to the corner of a stream or a river. So when blood gets caught here, then the blood clot will form there, okay, because you have a left atrial appendage. So one of the interventions for people who has that, so a non-pharmacological alternative to, because we're gonna have to put the patient on anticoagulants. in order for them to not have a PE, a stroke, or a heart attack. So what they'll do is put an implant right here. So they eliminate the appendage. So therefore, is there anywhere for blood to pool? No. So if you eliminate that, is there likely to form a clot? I mean, it's gone. You put a patch there. You eliminate, you obliterated the left atrial appendage. So is there anywhere for blood to pool? No. So therefore, can you form a clot? Okay, so that's an option. Okay. So let's look at other treatments. Manifestations, of course, are manifestations of low cardiac output. Plus, if the patient gets a stroke, then manifestations of a stroke. They get a heart attack, manifestations of a heart attack, PE, manifestations of a PE. All three are fifth semester topics, so they're in a different chapter. So let's go now to the management. Okay. Treatment depends whether it's new onset AFib or if this AFib has been around, but for how long. Okay, so good thing we don't decide that. The doctor will decide how to treat the patient's particular AFib. If it's new onset, meaning you literally saw it happen. Okay, so you know the patient admitted, let's say this usually occurs in pregnant women. So let's say patients in labor, they're on a cardiac monitor, you saw the rhythm right before you. Okay, you saw it in real time. Oh, AFib, right? So if it's new onset, the doctor can decide to do cardioversion for that patient. We'll discuss cardioversion another time because it's on a different page. So treatment of AFib depends on the cause, the pattern, and duration. So again, new onset, what's an option? We can do cardioversion. Okay, so I'll explain cardioversion another section. If the AFib is, let's say, has already been ongoing, most likely, the patient has had the symptoms but never went to get diagnosed, meaning they've been having the palpitations, the dizziness, shortness of breath, but they just brushed it off, meaning, I'll be fine. They just rested. Okay, so it went on for days, weeks, months already. So chances are, is this new onset or is this already chronic AFib? Okay, so it's been a while already. So the cardioversion is not an option anymore. So remember, there are two effects here. One is loss of cardiac output, and second is the clotting, right? Okay, so when we admit the patient, the first priority is the heart rate. If the patient's heart rate is between 60 to 100, we don't worry. If the patient's heart rate is over 100, especially if it's over 120, do we need to treat it now? Okay, what were the medications used again? If you remember in sinus tachycardia, what were given? Beta blockers or calcium channel blockers, right? Okay, so that's what will be given to the patient. So we need to control the rate. If the rate is high, that's what we call AFib with rapid ventricular response. Because what happens is sometimes if the AV node is not doing its job, the AV node will think that each of these waves here, these fibrillatory waves, these F waves, they're not P waves, right? So therefore, remember the job of the AV node was what? No, it's very important job is to delay the transmission, remember? Okay, so another important job of the AV node is to distinguish between a true SA node electrical impulse and those that are not. So if the AV node is doing its job, then the ventricular rate will remain normal. If it's not doing its job, meaning if it's duped by the F waves, meaning it thinks that, oh, these look like SA node impulses. So if it transmits each one, what will be the result? Meaning if it's duped by each one of these, and each time the AV node, oh, that looks like a normal impulse, and it will transmit it, correct? So what do you think will happen? if it responds to each of these, what will become of the QRS number? High or low? If it responds to each one, meaning instead of identifying it, oh, that's not a P wave. What if it got duped? Meaning every node thought, oh, okay, I think that's a P wave, and it transmits the signal, transmits the signal here, transmits this signal, transmits this impulse. What will happen to the ventricular rate? Very, very high. And you already know what happens when the rate is really high. What happens to cardiac output? Drop cardiac output. So that's the number one priority. We look at the rate. How is the rate? The rate is under control. We'll say, phew, and then we'll just worry about the clotting problem. All right. So again, if the rate is super fast, we need to give them calcium channel blockers or beta blockers first, and then the anticoagulation. Okay. Now, the type of anticoagulation that will be chosen will depend on the patient's underlying problem. So since anticoagulation is discussed under pulmonary embolism, I won't test that for exam 3. Okay, that will be for next semester. All right. So if the patient, like I said, if they do an echo and they see a left atrial appendage, then that would be a choice for the patient. Meaning, especially if they have contraindication for anticoagulants. I mean, if you're 80 years old or older, is it really a good idea to put you on an anticoagulant? I mean, you know what happens to 80 years old or older, right? They'll fall. Okay? They'll fall, and then what happens if they're on anticoagulants? Fall, hit their head, they'll bleed, right? So besides the beta blockers or calcium channel blockers, they need an anticoagulant, especially if it's a permanent type of AFib, meaning no matter what we do, they don't convert. Then we consider this is persistent or permanent AFib, then they'll be on anticoagulants for life. Again, the choice of the particular type of anticoagulant will depend on what caused this patient's AFib. Okay, so let's go now to the causes. Chart 22-2. Number 1 again is age. What did we say at the beginning? AFib is the most common dysrhythmia for? Okay, 65 and older. Okay, so age, the higher your age, then the higher your risk for AFib. Hypertension. Now, it depends what causes this hypertension. If the hypertension is caused by a valve problem, right here, valvular heart disease, then doesn't matter whether it's stenosis or prolapse or regurgitation, any valve disorder, the only anticoagulant approved for valvular AFib is warfarin. What is warfarin? Coumadin. Okay, so that's the vitamin K inhibitor. So that's the only thing approved. Why? Well, the drug company said so in their trials. If the patient's AFib was caused by a valve problem, their anticoagulants did not work. Does that make sense? What's wrong, Joyce? What did you not understand? So the drug companies do clinical trials, correct? Before they submit it for approval for FDA. Okay. In their clinical trials, so patients with all AFib, okay, they tested everybody. So they had sample sizes, and then they found out that those that had valvular AFib, meaning AFib caused by a valve problem, their anticoagulants did not work. The only one that worked was warfarin. Period. Any question? What do you mean, how come? That's the result of the trial. They did clinical trials, and that's the result. Those that had valvular AFib, only warfarin worked. You understand? Okay, so that's why, what's the only anticoagulant we use if it's a valvular AFib? Warfarin. For all other types, we can use the 10A inhibitors like rivaroxaban, apixaban, right? The problem with heparin will work for whatever AFib, but can you give heparin forever? I mean, we have to send this patient home, correct? So therefore, we can't put them on heparin indefinitely, only during the hospitalization. So here are the other causes, risk factors rather: diabetes, sleep apnea, smoking, etc. Okay. And these are the types of AFib. Paroxysmal means it comes and goes. AFib now, back to sinus. A little while later, back to AFib again. So that's what we call paroxysmal. Sudden onset, sudden cessation. Persistent, more than 7 days. Long lasting, more than 12 months. Permanent, about the same as long standing. And then non-valvular, again, any AFib without any evidence of any valve disorder. All the patient's heart valves are normal. They have AFib, then that's definitely non-valvular AFib. So how do heart valve problems cause AFib? So let's look at, say this is your heart, and we have 4 valves, correct? We have 2 AV valves, 1 pulmonic valve, 1 aortic valve. So if a valve either does not open or close, what happens to blood flow throughout the heart chambers? Is there, Miss Chosang, is it still gonna move in one direction? Some blood will go back to the previous chamber, correct? So you disrupt the unidirectional flow of blood. So what happens to the pressure inside the heart chambers? It will increase. And will that irritate some cells here, especially in the atria? And can that cause them to fire abnormal signals? Okay, so that's one way the heart valve problem or heart failure can lead to atrial fibrillation. Okay. So let's go to the medications now. So we talked about calcium channel blocker, so that falls under drugs to control the heart rate. Other drugs will either be antithrombic. Now, antithrombic are not anticoagulants, okay? So antithrombic can be, let's say, antiplatelet drugs. Let's say aspirin and clopidogrel. But most people are going to be on anticoagulants. Okay, but this is an option. So here, indicated for most people with non-valvular AFib. I'm not testing this chart because we're not doctors. We're not assessing this patient's risk for clotting. Here are the calcium channel blockers and beta blockers. Okay, they fall under controlling the heart rate. Now, there are drugs we can attempt if the patient's AFib is, let's say, fairly new, but not really new onset. So if it's lasting 48 hours or longer, definitely we use anticoagulants, right? But there's a chance that the patient's rhythm can still convert using medications. So the medications used here to convert the rhythm back to sinus, from AFib to sinus, are the following. But again, you already saw the table with the drugs earlier. So if these drugs can convert AFib to sinus rhythm, what are dangerous side effects of these medications? Another dysrhythmia. And these are given IV. So monitor the patients closely. So they work if they're given within 7 days from the onset of the AFib. All right. Again, look at the side effects. The problem with the QT interval is when you do that, when you have a drug that does that, other drugs that do that, you familiar with ondansetron? Zofran? Okay, Zofran has the tendency to prolong QT interval, right? So it's not completely harmless, so they can do that. So if the drug has that potential, then that means, can these drugs be given outside a cardiac monitoring floor? No, these drugs will never be given outside the ICU, outside telemetry, outside a stroke unit. Okay, so they can only be given on a cardiac monitoring floor, right? QT interval, when this is prolonged, that usually leads to ventricular fibrillation. What is VFib? You did CPR BLS with okay, so this is it a perfusing rhythm? No, this is a non-perfusing rhythm. Patient will die unless you do CPR. Okay. So we mentioned beta blockers already. There are only 2 calcium channel blockers. They were listed here. So the only 2 approved for AFib are verapamil and diltiazem. Okay, again, these are IV infusions. We did antithrombics. We have to control the rhythm and convert the rate. Okay. There's a electrical cardioversion is mentioned here, so let's discuss this now. So what is electrical cardioversion? Do you know what a defibrillator is?
Yeah.
Okay. So this is your defibrillator. Okay. The machine used to do cardioversion is the same machine. The only difference is there's a synchronized button here. If you're using the defibrillator as a defibrillator, you leave the synchronized button off. Again, if you're using the machine as a defibrillator, you leave the synchronized button off. Understand? You keep it off. If you intend to use this as a cardioverter, same thing as an electrical cardioverter, synchronized cardioverter, same thing. You turn the synchronized button on. Are we clear? All right, so what's the difference? If it's working as a defibrillator, if this is a defibrillator, the electric shock will be delivered when? So you put pads, right? On the patient's chest here and here, right? Okay, so you attach them to here, and then let's say the rhythm is VFib or VTAC. What will the machine do? It will say shock advised, correct? Right. And then so you will charge the, you turn on the machine already on. You charge it to, let's say, 150 joules. And then what do you do next? You shout.
Clear.
Okay, you say clear, and then you press the shock button, correct? Right here. Okay, so you press the shock button, and then when will the machine deliver the shock? Instantaneously, as soon as you press the button. So you press the shock button. That's why you said clear first. Clear, nobody touch the patient. Press the button, and then the shock will be delivered. Okay, right there when you press the button. When you turn the synchronizer switch on, it's no longer a defibrillator. It's now a cardioverter. Okay. We do this for AFib. So you turn it on first. Of course, the patients have the pads already, and then the synchronized button is on. So therefore, is it a defibrillator? What is it now? A cardioverter. Okay. So what will happen when the sync button is on and then you press the shock button? The electric shock will not be delivered instantaneously. It will take a few seconds. Why? Because the machine will sync with the patient's rhythm first and then deliver the electric shock at the peak of an R wave. So if this is the patient's rhythm, they're in AFib. The electric shock will only be delivered at the peak of an R wave. So it'll take a few seconds before you see the shock delivered. So it will sync first, and then you will pick one of these R waves and then deliver the electric shock there. So that's why it's called synchronized cardioversion. How much electricity or voltage is used? Well, we usually start low around maybe 50 joules, and we can go up to 100 because we sometimes can't convert the rhythm with one shock. Sometimes it may take up to 3 shocks, okay? Now, when we do synchronized cardioversion, this is not like because in defibrillation, what were the 2 rhythms that we defibrillated? VFib and VTAP. In both rhythms, was the patient conscious? I mean, you remember BLS, right? Okay, so the patient is in VFib or in pulseless VTAP. Were they conscious? No, that's why you were doing chest compressions, correct? All right. So therefore, did we need to sedate the patient or give them a sedative? No, because they were already unconscious. There was no cardiac output, correct? That's why we were doing chest compressions. Now, is this the case in AFib? Is this patient unconscious or no cardiac output? No. So are they most likely awake? So can we do this procedure with this patient in this state of mind? Can we just do, hey, Caroline, we're doing hey, you're in AFib, okay? So we're gonna do a cardioversion. Hey, you ready? Okay, here, bite on this stick, okay? To take the edge off, okay? Because we're gonna give you an electric shock. Can we do that? No. So what do we have to give Caroline before we do this? We're gonna give her a little sedative. We have to sedate her so she doesn't feel the electric shock. Because what are we gonna do? Just give her a trick and then, okay, hold on to her, okay? Are you ready? Well, it's like Rambo, right? It's like electrocuting Rambo. Okay, so this has to be planned, right? So we sedate the patient. Well, if we had a chance, of course, we want to have consent. But if it's like an emergency case, because we can do this in the ER, kind of an emergency situation. So if that's the case, then consent is, desired, but not really necessary, right? Because I mean, she's here, so in the ER, so we assume, yeah, she wants it. Okay, all right. So that's the case. So for cardioversion, can we just do this without any preparation? No, usually most cases are scheduled, but again, in the ER, we can do emergency cardioversion. But in both cases, does the patient need sedation? Yes, because they're awake. right? AFib usually doesn't cause loss of consciousness. Okay, there's still some cardiac output, not like VFib or VTAC. So any question on cardioversion? So what's the differences between cardioversion and defibrillation? When is defibrillation used? VFib, VTAC, which the patient is unconscious. And when is the electric shock delivered? Randomly, right? Anytime you press the button. Whereas in cardioversion, who gets it? AFib, A-flutter. Okay, those are the examples. And when is the electric shock delivered? No, the timing, a peak of an R wave. Okay, and do you give sedation? Yes. So please sedate the patient. So that's for cardioversion. All right. Oh, now, obviously, when we do cardioversion, we can do it emergency, right? So that means, is it new onset or persistent permanent AFib? If it's an emergency. New onset, obviously. Okay. So if it's new onset, was there likely a clot already? If it's new onset, not likely, not yet. Okay. However, so if this patient has, let's say, persistent AFib, which means it's been on 7 days or longer, correct? Can we do the procedure? You think you can do it anytime? Okay, because after 7 days or after 48 hours, in fact, was there possibly a clot already? Yes, that's a big possibility. So what could happen if we give them the shock with a clot somewhere in the atria? It will release the clot, correct? And the patient could have a stroke, a heart attack, or a PE. So if that's the case, then the patient has to be placed on anticoagulation first to make sure there's no clot before they can do cardioversion. Does that make sense? Okay. Now, even if we did that, are we sure that there is no clot? No. How do we make sure? Let's do an echo. Okay, so they'll do a transesophageal echogram. TEE meaning this is an endoscopic type of echo. 2D echo, transthoracic, we just put a probe over here, okay, to look for, look at the heart chambers, look for a clot. A transesophageal is more accurate because the probe is not put over the patient's chest wall. It's put into the patient's esophagus. So it's an endoscopic procedure. We'll put the probe here inside the esophagus. Now, is that closer to the heart? Which one's better? The one over here or the one inside the esophagus? The one inside the esophagus, that will give us a even better picture of the heart chambers. So this will be done. So if it's over 48 hours already, okay, we can't do it anymore because the patient may have a clot already. So we'll put you on anticoagulants, maybe about 2 weeks, come back 2 weeks. We'll do a TEE, make sure there's no clot. And then if there's no clot, then we'll do the cardioversion. Does that make sense? Okay, so that's an option. So here so it's not 2 weeks, 4 weeks. Okay, so patient may be on anticoagulant for 4 weeks, and then they'll do a TEE, and then they can do the cardioversion. And one more procedure. So let's say we did cardioversion, nothing happened. It didn't work. Patient's still in AFib. There's one more chance that they can treat this. We already did cardiac therapy. We did the dofetilide, amiodarone, ibutylide. Okay, so didn't work. Patient still in AFib. So the doctor can do one last thing. Remember, we said earlier that this rhythm, what's firing these signals? Is it the SA node? Obviously not, because they're not P waves, right? So something else is firing them. Where? We don't know. So to find out where it is, we'll have to take the patient to the cath lab and do an EPS right here, electrophysiologic study. So what they'll do is put dozens of electrodes on the patient's chest and then analyze which parts of the atria are firing these signals, these electrical impulses. So once they're found, they'll map it electronically, and then the patient's already in the cath lab, right? So they'll go in to an artery and then use a high frequency, low energy sound waves pass through the catheter, meaning it's like a cardiac catheterization procedure. But instead of opening an artery, what's this doing? It's going to destroy those sources. So we can't do this unless we know what to destroy, correct? So we'll do an EPS first. That's why I see them, just like what George W. did. Remember Katrina? What did George W. say? Mr. President, what are you going to do about Katrina? What did he say? George W. said, we're going to find her. We're going to bring her to justice. You don't get it? Hurricane Katrina? Oh, she got it. Okay. So it's going to be like this, all right? So we're going to find them first. We're going to find these cells that are producing these electrical impulses, see? With the EPS. And then once we see, there you are, you suckers. Okay, so then we'll do the catheterization. And using high frequency, low energy sound waves, they're going to burn and destroy those cells. Okay, it's going to cause thermal injury, localized cell destruction, and scarring. So once they destroy those, will they still be firing those signals? They'll stop because they're dead. And then hopefully that cures the AFib. All right. What could go wrong with this procedure? Because where are these cells located? In which chamber? In the atria, right? So therefore, when we pass these high frequency sound waves to burn those tissues, can we possibly destroy something else? Could it include the SA node? Unfortunately. So if it's a little too close to the SA node and then we end up destroying the SA node, then now what? Patient has no more SA node. So what will the patient have? So they'll require a pacemaker. So when you see pacemaker as part of the therapy for AFib, that's not really for AFib. It's given why? Why did we put a pacemaker on an AFib patient? Because we did this. Okay, because we did ablation therapy and then we inadvertently destroyed or damaged the SA node. Now we have to give the patient a pacemaker. Okay, because the SA node no longer works. We destroyed it. All right. So is pacemaker part of to treat AFib? No, it was only given because we messed up. Okay, so it was a complication of what procedure? Ablation procedure. No, the EPS is just to map. EPS is not invasive at all. We just put electrodes, okay, so just to find the cells we want to destroy. Okay, so that's the EPS. The ablation therapy is a catheterization procedure. Okay, this is now using a catheter through radial or femoral artery. No, just like a cardiac catheterization we used to treat a heart attack. No? We'll skip MACE and mini-MACE. Left appendage occlusion, I already explained earlier. They'll put a patch to eliminate the appendage. That way there's no more blood that enters there, therefore no blood clots. So here's a visual representation. Okay, so that's how they close it. This is the patch. We'll stop at aflutter. Now, aflutter is similar to AFib. As far as causes go, look at but if you compare it to AFib, unlike AFib wherein it was very irregular, correct? Aflutter is very irregular. Look at these flutter waves. Okay, they're very, it's also called sawtooth appearance. You know, a sawtooth. You know what a saw is, right? Okay, so it looks like a saw, right? Okay. So there's nothing else like it. Very easy to identify flutter. There's nothing else close to it. Treatment is really similar because the effects will be the same as with atrial fibrillation. So causes low cardiac output, can cause blood clots. So the treatment will be exactly the same. Okay, so I won't repeat it because it's really the same. All right, we'll stop here. We'll continue next week.